let's just go through the esophagus. Again, the esophagus has bubbles in it. So we'll use some Infocol to sort that out. Again, we're at the gastroesophageal junction here. Also, the esophagus kind of has the appearance of a bit chronically inflamed. Not terrible, but it's definitely there. Like it's a little bit kind of granular, the mucosa. Here's the gastroesophageal junction. I'll push in, I pull back onto it to get my measurement. Caps on it now, tips on it now. So 40 centimeters, that is, to the gastroesophageal junction. And did we do endoflip?
There was an endoflip done here. The distensibility was 0.7 when we had a balloon pressure of 23, and 1.3 with a very high balloon pressure of 35.
All right, so distensibility of 0.7 is well into the range of being very abnormal. So there's something wrong with the gastroesophageal junction. The stasis of saliva and the appearance of the mucosa was consistent with chronic outflow obstruction. There is no hiatus hernia. The manometry and the endoflip are together on the diagnosis. So this is that case of Chicago EGJ outflow obstruction. So we'll treat it the same as type 2 achalasia. We attempt. Again, we'll put out the needle. Open, please. Open. Inject. Stop. So that didn't work. Let's do it again. Inject. So then just let it come up, come up, come up. Okay, let's have the knife, please.
When you start posterior approach, do you think of maybe moving the patient because you probably will have difficulties with the fluid pooling into your tunnel entry, and it's maybe harder to get in?
Yeah, you can do that. I have to say, I don't do that, but we'll see how we go here. So Jasper, we are a little quarter round. Thank you. Open, please.
The settings are okay?
That's a good question. The settings are okay. So again, we're endocut Q effect 2 and spray 4. So we're going to do the same thing. Get in. So we're in already. Make the stretch a little bit pressed forward. Okay. So already we are into what is potentially an acceptable tunneling situation. The fluid is annoying. I agree with that. So we may, but I don't particularly, if I can avoid turning the patient, I'm going to avoid it, right?
It's just for making that entry and getting in the tunnel.
Just entry. I'm going to go a centimeter further. Then I'm going to actually let you do this, I think. I'll just tell you how to do it. So 1 tap, 2 taps to get through, lift up, do your first one with endocut. And then further, we're going to inject behind and we're going to proceed down with the myotomy.
If you have never done it like that, can you just turn the scope and turn it into an interior?
You can, but it's quite difficult. I mean, it's much, just trust me, it is much easier to do it posteriorly. So therefore, you should learn this. Okay.
So the entry is just here.
Yeah, you lift up.
Yeah, okay. So I'm insufflating all the time, lift it up, and I have the knife in my hands.
Yeah.
Okay. So I think I'm only through the circular.
Agree with that.
You see the circular, not helping. So I tried to inject a little bit already or you think we should immediately go?
Well, I don't need to go full thickness because we're within 5 of the junction. Yeah. So you can inject a bit first.
Okay, that's close. Okay. Open. I will do another tap.
Oh, yeah. Or you can blunt through this. So just push the knife through the longitudinal. And just push hard through.
Yeah, you feel some resistance,
Okay,
and now
that's
not
gone through.
anymore.
And now
Yeah.
lift up. Now lift up in this position. Okay. Insufflate a lot.
Yeah, and cut will
Cut
still
up.
do it.
Yeah. Nice that you've got your hand on the knife. You need to do that. Okay. Now
so
inject
we see
behind.
there it's splitting close.
A lot. Keep going. Keep going. Keep going. Keep going. Direct the knife away into the distance.
So,
yeah.
And not take the vessel into with the knife.
Yeah, I would explain it when you can. See.
You need to do that with the cutting. Yep.
Okay. Unfreeze.
Yeah. Okay, so close. We'll inject more first. Okay, so it's injected, you can open. And it's a bit more difficult to see that vessel now, but so I will try to hook the knife here, but I think I still have it.
But that's okay. You're not pushing into it like you're.
And so now I orientate with the scope
Yeah.
a bit to the left.
Yeah.
And I will do spray.
Yeah. Very nice. Apart from the last tap was dangerous.
Okay, close. Open. You say under, orientate, still a little. Well, I think we're almost back in the middle.
Mm-hmm.
And it's thicker. I'm not through.
Mm-hmm.
So I do more taps. And I go pull back slower in the cap. It's going slow. The two.
What's going slow?
With the spray, I feel like.
Well, there's another way that you can do it, which I'll show in a minute. But this is the most.
Because now, if you open it, I feel like I can spray onto it.
Okay, yeah, go on.
Yeah. So carbonized, and it's very difficult.
Yeah, so this is also an option, obviously.
Getting a lot of
Now you're doing selective modeling.
So I will put it back behind. Open. And dirty. Maybe I come a bit closer to the scope. So I have more control over it. Okay. So I have the two layers now. Okay. Let's see. Still in the right orientation, I think. Okay. Close, please. Open, please. So I will now spray onto it again because I have a nice space behind it.
Mm-hmm.
Close. Open, please. Still going into the right orientation.
Feel it too much on the right, I think.
Okay. So then I prefer to then put the knife again so I can reorientate a bit.
I think that's the way to do it. It should be too far away from the skirt. Exchange the skirt with. Yeah.
The phone is going off all the time.
I have
Close. Okay.
So you need to be very precise going
Yeah.
across the junction.
Yeah.
In the direction that you go.
Okay, I'm still pressing. I'm gonna put a bit more. Okay, open. I feel like I want to put it under because the space between the muscle and what's behind
I think
is too.
both techniques are fine as long as
yeah.
you're being safe. Too much tension on it, maybe.
Close. Open. Okay, I have a bit of a wider safety margin now, so I will spray on.
Starts to open up.
Start to spray on it again. Just make sure that the orientation is still all right because it's turning a bit to the left, maybe there under it. Close. Open.
This is nice. I think this is nicely what you can do to kind of push over the junction almost. Watch out for the edge of the tunnel.
Yeah.
Let's delineate a bit the edge of the tunnel.
Let's be urgent because it's a 10 time. Open.
I don't feel anything.
It's the watch, my watch, I feel it. Open, please. I'll pick it up a bit here. A bit too far away, so go. Close. Still going in the right direction. I'm gonna inject a bit more. I didn't feel like it did a lot. Okay, open. Okay. In the right direction. Yes. Also, not sure. Close. Open. Do we have everything here? Like lift it up a bit here. I think there's some fibers, or maybe not.
All right, then. Thanks. Let me have a impact. So well done. Not easy to do that. Really nice job. We'll finish it off and then we can talk about that. Open. So we just check the direction. We're going that way. Close. A little bit of the muscle still connected here. Open. That's okay. Here as well. Close. So nearly at the end. This is a more standard, what the gastric myotomy looks like. Open. Like that last one was not standard. Yep. Still quite thick here, actually. Big vessel under there. Close. So indeed, that's one way to try and avoid vessels, try and separate them out. This guy does not look interested in being separated out and it's pulsing quite a bit. So maybe we'll avoid him. Avoidance is the key. Here we got something that's trying to bleed. So we can use spray on it. And on the edge here. Maybe at the bottom here. Diaphragm is reacting to being injured. Okay. Looks nice. Here's the entry. Check the junction. That's great. Check the patient's got quite distended here. Stomach's not so distended anymore.
You can imagine a little bit of gas going through that, the final end of the myotomy.
But it's still
quite soft,
not sensitive. So, okay, we're going to close up. Just check for bleeding. So we say the little time thing to the anesthetist. How long we've got left. We're clearly over the junction. All the muscles clearly divided. I don't see anything bleeding. Maybe this little guy here. A knife, please. Thanks. So maybe we can already open some clips. Okay. Yeah. Just clean up these vessels in here. I think it's always a good idea. Often people look at me with amazement when I'm doing this, like, why are you bothering to be so meticulous? But I mean, you wouldn't leave a surgical field with bleeding, would you?
No, and it's not going to be very easily accessible again.
Well, I mean, yeah, you can access it again, but why would you, why would you want to?
Why would you want to?
Yeah, let that happen. You can switch the spray down a bit if you want. Now we're on 4, we can go to 2 probably. Where is the program then? Yeah. Yeah. So that we're less destructive with the spray that we're doing. It'll still be hemostatic, but less destructive. Okay, let's have some clips then, please. Just investigate this. So of course we're going to close this anyway, but stop. Was bleeding a bit here, wasn't it? I forgot that from before. Does that matter in the context of it being clipped together? I don't think so, but on the other hand,
You can
why
see
take
the
the chance? Yeah. Nog 10 minuten mensen. Good. So closing a posterior tunnel is easier than closing an anterior tunnel.
It looks as though it would be, but
because it's just exactly where the clip comes out. Open, please. Fully open? So the fluid is making it a bit annoying, but I don't think it's undoable. So again, here we can really match the clip to the orientation. Okay. Let's go now. Shoot it. Put one below that now. Yeah, another clip, please. Open. less so?